Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Welcome, everyone, to the Friends of NPACE Podcast. I'm so excited to be here like always. Today, our guest is one of my favorite. She has the record for the all-time most listened to podcast that we've ever done. That's right. It was amazing. Also, when we were together last time, you talked to us about your pain control practice, and you talked to us about acupuncture. We've done that as well. And then you were recently with us in Delray Beach speaking about musculoskeletal pain.
Yes.
So I'm so glad you're here today. This is Dr. Heather Jackson. I'm going to tell you a little bit about her, but what's so exciting about this podcast is that it's going to have some CE credit with it, thanks to an unrestricted educational grant from our friends at Haleon. So very grateful for them. And I know as a primary care provider, this is a topic that I deal with every single shift I work. So Heather, we're glad to have you here with us. You're a pain clinician practicing in supportive oncology and palliative care at Vanderbilt, at the Vanderbilt Ingram Cancer Center at Vanderbilt University Med Center. You're also an associate professor of nursing at Vanderbilt University School of Nursing, as well as the Vanderbilt School of Medicine, and a founding board member of one of our favorite organizations, the Pain Medicine Academy for Advanced Practice Providers, PMAAPP. Did I get that acronym correct?
You did, yes. Very good job.
Thank you. I forget one of the A's or the P's typically in there, so I'm glad I got it. But you're a nurse scientist too, and you actually did a lot of research on acupuncture, ear seeding, and the treatment of pain and opioid dependence. So I was grateful that you shared that work with us.
Yeah.
And then in Delray, we talked about musculoskeletal pain, which I seem to have more and more of.
It happens as we age, doesn't it?
Yep. Yep. Sometimes it's just sleeping wrong in bed.
Yeah. Yes.
Yeah. So we're going to expand. So if anyone wants that presentation, we actually will have it on the Learning Center, and you can find that at learn.npace.org. But we're going to follow up, and we're just kind of do rapid fire and do some questions here as well. So Heather, as a clinician, we're just going to start super practical. When it comes to patients with musculoskeletal pain, like acute, the less than 4-week window, what are your first 3 moves before you ever talk medications or actions or anything like that?
Yeah, first and foremost, got to get a good history. I need to understand what's the type of pain, how is the patient experiencing the pain, to your point, how long have they been dealing with this before they come in, did they get in right away or did they wait 3 months? And then how have they been struggling with it? What's making it worse? What's making it better? And most importantly, how's it impacting their life? Because that's really important. We talked about that with the biopsychosocial model in our lecture. I then move on to a focused exam. I'm looking for stability, tenderness, range of motion when I'm looking at those joints. And then overall education. This was a big thing we talked about in Delray. And I find this so many times with practitioners, they forget that this is an intervention in of itself. So starting off with first line treatments, seeing what's been helpful, what hasn't been helpful, what are they trying, what's their understanding of what could be helpful for this pain, and then making sure that patients understand aggravating things to avoid, lifestyle interventions that can improve their pain. Examples would just be proper rest, giving time for an injury to heal, for 100% recovery, and then looking towards preventing future injury is huge when it comes to that patient education. But as I always say too, that's an intervention, and make sure you're documenting this intervention with your patient, the time spent with the patient for that.
Yeah, I don't think clinicians do that enough, right? So when you see someone, always chart disease education, treatment education, health promotion education, like do that. It's billable and it counts. That's what we're really good at. You brought up something. So old cart, old card is never dying. Like,
Yeah.
that's the first thing you should always document and go through in your head. But you added like quality of life and outcomes and
Impacting.
activity. Yeah.
Mm-hmm. Yeah.
Okay.
And that comes to pain experience. Like when we were talking about the definition of pain in Del Rey, like my perception of pain and how I'm experiencing the same injury could be very different than how you would be experiencing an injury. So we have to make sure, again, we individualize as well, as all the evidence tells us to do, right? Everyone's not treated the same. Everyone doesn't experience a condition the same way.
Yeah. Agreed. And just making sure you know those red flags. Oh,
Yes,
the red flag. We're going to talk about those in a little
for
bit.
sure.
All right. So you did cover acute versus chronic pain in your lecture. Does that change what we do day one in primary care? Like, what's the definition of each? And like, how does that change how we think about musculoskeletal pain the very first time we see a patient?
Yeah, for sure. When we're thinking about the pain, we want to keep this in mind with that individual experience. When did some type of injury possibly occur? When are they coming in? So acute pain is going to be time limited. It's protective in nature. It's going to be sudden in onset. Usually you're having an injury that's associated with it. So that's a good history to get, right? Did some sort of trauma occur? Like what caused all this? And usually acute pain is going to be defined as less than a month. Chronic pain develops from acute pain, unfortunately. So that's really our key, to try to intervene there to keep it from developing into chronic pain. And this can become maladaptive. It's persistent, defined clinically 3 to 6 months lasting in that duration. So pretty much beyond that 3-month period.
Okay.
And the symptom is now developing into actually a condition in and of itself for chronic pain versus I'm having a pain and that's a symptom that I'm dealing with. It then starts to become something that the patient is experiencing as a whole overall condition, and it can inhibit function.
Okay. So chronic pain is past that 3-month and it's maladaptive, right? So we're trying to prevent an acute. You just said something that's really important. Acute pain is protective. Can you expand on that a little bit and what you mean?
Yeah, so we're having acute pain because the body's saying, this hurts, ouch, don't step on this ankle. Don't move this elbow until we get something, in play here. Chronic pain is, I'm experiencing this chronic pain. I can't seem to stop this disruption in this nervous system signal. And then it's starting to impact, maybe I don't move as much. Maybe I'm not doing as much. Maybe I'm a little bit more irritable now. And you can see where it becomes that maladaptive function there.
Yep, that makes total sense. Okay, I'm taking the audience knows. I take notes.
I love
you all
that.
should be taking notes too, writing things down. All right, that's very helpful. All right, so I say I'll write a lot, sorry. Podcast people. I want to move on to places, the common places where we get acute musculoskeletal pain, especially in an aging or active patient, that 30 to 60 something weekend warrior kind of group. What are the go-to questions to assess for red flags and further assessment? And is it really like area specific? Should we go through knee and hip and low back, or are there some go-to red flags that we should always consider?
Yeah, I love talking about the red flags because I think they're good highlights for a clinician. I kind of group it into where I would classify the red flags. So signs of infection. I'm looking for fever, chills, night sweats. Is there localized redness? If we are looking at the elbow, the knee, are we seeing a discoloration in the skin? Has there been a recent invasive procedure? Because then we're, going to start thinking about perhaps something's not healing correctly there. Then neurological deficits. Are they experiencing any numbness or tingling or weakness in extremities? Obviously, with back pain and concerns, if we have any changes in bowel or bladder control, we'd be concerned about nerve compression and neurological emergencies. And then malignancy, obviously, can be a concern too. For there, I tie it to unexplained weight loss, night pain, or pain not relieved with rest. And then, of course, tie that in with a history of cancer, then that's certainly going to be a huge red flag to be considering there. And then vascular compromise, if we have cold, pale extremities, there's swelling or discoloration again on the skin. If there's pale legs, we're not seeing good hair growth, that sort of thing. Any history of blood clots and vascular disease.
Okay.
And then
So
finally, sorry.
Go ahead. I'm writing notes.
My last one that I kind of clustered into is there a concern for fracture or dislocation? Did they report a recent fall, some sort of trauma, motor vehicle accident? Do we see a deformity? Can they not bear weight? Can they not perform range of motion?
All right. Infection, neurocompromise, vascular compromise, malignancy, and either fracture or dislocation.
Yeah. Trauma.
Always. Mm-hmm. Okay. I got those. See, this is my weak spot. Neuromuscular. Okay, this is good. Assessment really lines up with this. And sometimes when people have pain and we don't know what to do, we overuse radiological testing. Mm-hmm. If someone's hurting, they automatically want an x-ray of that area. So what are just a few guardrails? And then when should we go, absolutely, we need some imaging. Maybe it's not an x-ray, maybe it's something else.
Yeah, and this is a really great point to bring up, Terri, because every guideline that you read, and of course I brushed up on this for our conference in Delray, and every guideline you went to was like, it's not first line to do imaging. Do not get imaging. Do not run to imaging. Consider so many more things before you go down that algorithm. Mm-hmm. So it's a great reminder. So imaging is often overutilized, and it does lead to unnecessary healthcare costs, radiation exposure. And then occasionally, this is an important mark to think of when you're ordering radiology. I see this in cancer all the time, incidental findings. And boy, doesn't that complicate the picture. you came in for X and here we are at Z, So that's something to think about when you're ordering imaging.
I've seen that before in patients too. We're like, we're going to go get an image of this. And then you're like, wow, what is this? And then you have to chase. Other
you got
thing
to find a specialist. Where do they need to go? And it comes back to you because you ordered the imaging. Yes. So that's something to keep in mind. So avoiding imaging when the symptoms are mild, mechanical in nature. Are we seeing an improvement with conservative management? So we're on par there. No need for imaging. When we think about ordering imaging, we want to talk about those red flags that we just discussed. Okay. Obviously, that would be all right, we're going down the line of imaging. And then the results will directly influence our treatment decision. So if we know we have trauma and we're looking at possibly a fracture dislocation, for sure, we need to image. Those neurological symptoms that we talked about, if we're concerned for a nerve compression, absolutely, we need to get some imaging to see what's going on there with the nerves. And then, of course, malignancy concerns, we would want to make sure we get some imaging as well.
Yeah, and lab.
With that
and infections.
For sure.
Okay. So if we're suspicious about any of the red flags, then we should go down an imaging path first. But otherwise, give it a little bit of time.
Yes.
Because sometimes, too, when people have their first episode of, say, back pain, and 60% of us are going to have that sometimes, they think they're dying. And it's not better in 48 hours or 72 hours. And
and it's, to your point, it's kind of like the sick patient coming in for the post-nasal drip wanting the antibiotic. But, that's not going to help you.
I'm really sorry that you're having pain. But our x-ray won't help that. Let's think about other things. So if we're talking about musculoskeletal issues, specifically sprains, strains, tendinitis versus, say, a tear or a muscle spasm, they're all different. And the things that we're just going to manage are those sprains and strains and muscle spasms. How do we kind of differentiate them from, say, a tendinitis flare or a tear in something we should be thinking about? We could start with knee. How do we know?
So first off, I have a grid in my head. So you want to look at tendinitis versus tear. So tendinitis is going to be gradual, tear sudden. This happened all of a sudden. I fell out of a tree. That's probably going to be more a tear. Localized to the tendon would be tendinitis. The tear probably going to have some deformity, and it's going to be localized. Plus, you're going to see other impacted areas.
Okay.
The tendinitis certainly will be painful with intact movement, but with tear, you're going to have that difference in that range of motion, inability to move, and weakness. Then for your exam, when you're feeling, you probably aren't going to feel anything necessarily different when you're palpating with tendinitis versus a tear. You probably are going to notice a defect there. There's going to be a gap, but it's not going to feel normal. And then it's again localized with the tendinitis with swelling, but with a tear, it's going to be more diffuse. You're going to see more like bruising.
Okay. Bruising for sure. The point tenderness sometimes is so specific to a tendon, especially I think of elbows. If you just put your hands on those medial and lateral epicondyles, if somebody's got, or in that, yeah, that hurts.
Right, right.
Or patellar tendinitis, or yeah, those
Yes.
things hurt. Back pain is usually muscle spasm.
Mm-hmm. Mm-hmm.
Like it knots up and then it just hurts. It's like spraining your ankle.
Right. And you got to rest it. And the back's really hard to rest, just like with the ankle. You got to be up and on it. But conservative treatment typically is going to manage it.
Okay. All right. Well, let's move on to that. So we established it's a sprain, it's a strain, it's a muscle spasm. It might even be an acute tendinitis flare from playing too much pickleball.
Sure.
So it's a thing now, pickleball.
Yeah. Oh, yeah.
So before we even hit the prescriptions, what's the strategy? I mean, we'll talk meds first because everybody wants to take something. So over-the-counter strategy, what's first line?
Yeah, over-the-counter for sure, NSAID. That's what we go to. Topical or oral. We definitely want to go to that. And depending on where they're having the injury. And then that's always my first line of questioning too with the patient. What have you tried? What are you taking? And I do a good exam there and a history there. Acetaminophen, sometimes patients will go to as well, not realizing that that's not going to be as effective. And it's not really going to be helping with their pain symptoms.
Okay. So ibuprofen, naproxen, over-the-counter difloconate. I'm going to say that right.
Yeah. Mm-hmm.
I like that. I use it with people. I know we used to just like have a strip and put an inch on, but I'm just like, you know what? Massage that in.
Yes.
And then put a warm bag on it.
And a lot of patients forget about those topicals, and especially our patients that like we're sort of talking about aging population and we don't want to add another oral medication. A topical is great, and you can put it right where you're having the pain, especially if we have one area of pain on one elbow versus diffuse multiple areas of pain. The topicals are a really great choice.
Yeah, and you don't get the gut effect, right? We're not having
Mm-hmm.
issues in the stomach, the prostaglandin, and you could put it right where it hurts, and you know that absorption. Do you ever try to mitigate expectations with this? Because nothing's going to work on 100%. Like you're not going to be completely pain-free after 24 hours of using your.
Yeah, I definitely do. I do give those goals there too. That also, if I am giving you this NSAID and I'm prescribing this, I'm also doing it in addition to other things like the rest. So that doesn't mean that just because you might have some improved symptoms that you just get up and go do that marathon that you signed up for. But so that's where I definitely get into the discussion of expectations.
Yeah, if someone's got tendinitis or a flare like that, and that's what they've been doing, like playing too much, or they've, they're training for a marathon. Sometimes I dash hopes and dreams.
I know, and you hate to be that bad guy. Yeah. But then again, it's like, well, if you're not going to tell them who is, because they're not going to tell themselves that. So what they really need is you to be the bad guy and say, I'm telling you this is what's best.
I know you really want to do this, but you're going to end up with a chronic whatever if you continue to irritate the same spot.
Right. Or you won't be here next year. It's going to get to a point where we can't do them anymore, which would be upsetting as well.
And then we're into the chronic pain and maladaptive behavior. And
yeah.
Although I never discourage movement, sometimes overextending movement.
Yes.
What do you think are any of the mistakes people make with over-the-counter medications?
Yeah, great question. So a lot of times when I'm doing the history, I'll say, well, what have you tried? And they'll say, oh, no, I've already tried an NSAID. Well, then I'll ask, well, what dose? And that's where it can be very telling. I don't know that we can say you've tried it if you took a very small dose one time. perhaps we need to consider a higher dosing of it. Optimizing the dosing is really the starting point. And then I can say, let's move on to a different NSAID, or let's try some alternative. But I always start there and then remind again with that education component that, taking one at the really lowest dose and one time, I don't necessarily think we could cross that off the list that it wasn't helpful.
Yeah. You need a few days to try the medication
and optimize the dosing. Let me prescribe you the dosing. Let me tell you, how to take it and how to time it. And then let's move on from there.
I like that. Yeah. Checking for drug interactions and doing that. I still like the topicals.
I know. It's lovely. It really is to not have to worry about ingestion for sure.
Yeah, I agree. All right. So you are the guru of alternative and holistic pain methods. What should we consider? Someone comes in with knee pain or elbow pain or low back pain. What are we going to talk about along with the medications that we discussed?
Yes. So research tells us there's really no harm, no adverse events with our complementary treatments as far as movement treatments. So like yoga, Tai Chi. So let's say we do have to modify movement. And like you said, I don't want to tell people not to move. So I can offer some other options here. These also have a psychological benefit as well with a sort of a meditative piece. So those could be adapted for any patient. Meditation, imagery, hypnosis, virtual reality. These are all really good things too that might help with that psychological component of the rest portion of it, especially if we are frustrated that we're being limited in what we're having to do. Those can be really great supportive adjuncts. I call them adjuncts treatments, not necessarily alternative, but in support with, working alongside our mainstream options. And then acupuncture, I love, as you've referenced, so I'm pretty biased on that. But there is a lot of references to acupuncture being beneficial. Some combinations with chiropractic care, but there is stronger evidence with utilizing acupuncture.
Okay. I like both of those. I think good chiropractic care, especially too, if you've got a chiropractor who's, has a physical therapist in the office and is aware of pain medicine or sports medicine, and they're doing ultrasound in the office and stretching and doing all of the things. I like the idea of acupuncture as well, especially for back pain.
And I love the stretching component. It TENS units and trigger point injections with PT for sure. I love that partnership. Oftentimes we get in our practices and we have a referral source where it's someone that we trust and we know they can go there and our patients will be in good hands.
I love physical therapy. I know patients aren't always crazy when we say you need to see physical therapy, but we're talking about people with graduate degrees in muscles and tendons and joints and how they all work together. And I just they're the expert. Let's go talk to them.
Yes, for sure.
Okay. I need some acupuncture, just saying, and massage
acupuncture
therapy.
Helps us all.
It does. Go watch our show on acupuncture. That was really good. Return to work activities. So here's where I, as a primary care clinician, sometimes once someone else has seen a patient and they've written a note that they are modified or they don't have work, and then they're still having issues or they want an extension of that work note or return to activity. So do you have any rules for safe and timely return to work?
Yeah, I'm sure you'll agree. Shared decision making is key here, right? I mean, you're not going to just convince someone that this is how it is and that this is what you need to do, but engaging in that shared decision making, really respecting the time that's needed for healing, giving milestones of what can we do, what is limiting, but what are we able to do, what can we modify, using a graded progression for that of increasing our volume before intensity. So if it's walking or if it's sitting more, then gradually saying, let's sit we have to start off maybe for 45 minutes. And then on the 15th minutes of the hour, can we do some walking? Can we do some of that movement stuff that we talked about? And then adjusting from there, giving sort of goals that you work towards. And then, of course, addressing risk factors, deconditioning is always a concern, any equipment needs that they might need. And then to hit on the psychological readiness, this comes into that collaboration with the patient of trying to just help them make those goals, to set those realistic but yet curtailed to them goals. Like, what do they want to do? What do they want to work towards? What's preventing them? And then how can you help them sort of mitigate that?
I like that. I like the idea of alternative activities. You kind of hit on that too
Yeah.
with Tai Chi. I have both ends of the spectrum. And so people who are very, very active, when you tell them you need to stop doing this activity for a little bit, but what about stationary cycling, or what about
Right.
swimming, or what about
Yeah.
Mhm.
Yeah. But you do have to give them those suggestions, because just sitting there and saying, so don't do that, that's going to be very off-putting for sure.
Yes. And many of us exercise so that we don't murder other people. I'm
Yes,
just saying.
exactly. You see
We
where
don't
we
wanna-
tie in the psychological interventions. If I'm
right.
not walking, it's a problem for everyone.
Exactly. So I like the volume over intensity. So you can
Yeah.
do 5 minutes longer, or you can
Yeah.
walk, but just don't walk uphill on the treadmill, or don't be jogging, or
Right. Or if
okay.
you usually wear weights, don't wear ankle weights. Let's progressively do things. And I'm not saying you can't do anything. I'm just saying, let me help you work towards your goals, but we're going to have to get there gradually.
Okay. I like that. And I like the realistic kind of approach. I mean, it takes a bone fracture 6 to 8 weeks to even
Right.
heal and begin. Sometimes I think with muscles, spasms or pain or strains, that when you say to someone, it's going to be 2 months.
Yes.
Really,
Mhm.
they're like, what?
Yeah. Well, and then you feel a little better, and they get out and they say, well, maybe I can do that race, that 5K that I, signed up for, rather than sitting back on it if you're not 100%, but really educating the patient. You really do need to be 100%. And that's why we do the working small increments to get there, rather than just getting up out of the bed and saying, I feel great today, and now I'm going to just go right back to what I was doing 2 months ago.
Okay. Yeah, I think that's fair. That's good. All right. Let's do a quick lightning round before I ask you a question. Okay. Straight from the expert. PT order at the first visit, yes or no?
Yes, it's not going to hurt, but it really depends on what point did they come in. Like we talked about earlier, have you waited 3 months before you came to see me? Certainly we're doing some PT. Or did you literally just fall out of the tree and come right to my office? Then we might give it a little bit of time.
That's true. If you fell out of a tree, we're talking about other things.
We're talking about a lot of stuff we're looking at.
Yeah. Ice or heat?
Is what our evidence more so supports. It's funny though, a lot of patients certainly go to the ice, and I just say, if it feels better and you think it's helpful, certainly it's going to help with some swelling, but more support from the evidence with heat.
For heat. Okay. Topical or oral NSAID?
I like to start with topical if I can. I tend to go by, is the pain isolated? If it's the entire lower back, it can be a little complicated versus an elbow or a knee. But I think it doesn't hurt anything at all to certainly try the topicals first.
Yeah, or stagger them. Do them both, but stagger dosing. Yeah. Back pain, muscle relaxer, yes or no?
No, if I can do it. I can be convinced to do a muscle relaxer combined with physical therapy, and I'd be sure to tell the patient this is going to be short term. You're not going to be on a muscle relaxer for the rest of your life, but I'm happy to give a muscle relaxer if you don't think you can complete physical therapy. And I'll say that it's to facilitate that healing process. So usually a 6 to 8 month, maybe a 3-month window, and then we'll start going away from that.
Yeah, we've definitely limited in my practice how much we do that. It helps people sleep because it knocks you out, but really, as far as evidence for long-term,
we have a whole other discussion on sleep, right? And sleep hygiene, and a publication on that coming out, right, Terri?
Yeah,
Lots of other options.
Yes, read our sleep and pain article. Yeah.
Sleep interventions.
Acute injury, protect or encourage early movement?
Really say both, honestly. I would probably lean more towards protect, though, if I have to be picking one or the other, because I don't want people on it and re-injuring it and then delaying the recovery process. So I do really hone in on the protect. Let's modify. Let's look at what goals we can do for the movement. But first and foremost, let's protect it and allow time for the body to heal.
I think that's a really good point. I know there's a lightning round and we're getting tangential, but I worked in peds urgent care for years, and any kid who has been on a basketball team and rolled their ankle, right, or been in gym and it hurts, that ankle sprain or strain, and we do need to protect it, like wrap it and do the things, but they always wanted crutches and like, really need you to walk and heel strike and write your ABCs in the air with your toes and get moving.
Yeah.
But it's not going to feel great.
Right. Yeah.
So,
well, and even so far tangential, but even the crutches can cause some discomfort because they're not using them right, and then their wrists hurt, and then their shoulder, under their arms hurt. It's a whole other thing.
And they're kind of bent over. Yeah, it can be all those things. So patients get confused with it. You need to rest and protect it, but you also got to move it. Like you've got to walk on it a little, and they're like, wait, which is it? Like,
right. It's a balance.
I appreciate that you said both. Same with muscle and back pain. Like you maybe feel good flat on your back, but some yoga for low back and neck is going to make you feel better. You should be moving those muscles. Okay. So both.
Mm-hmm.
One red flag that will cause you to order radiology no matter what.
Loss of bowel or bladder control, huge for me. I'm like, all right, I'm worried, especially if we're having that back pain that's going on. I'm worried about some nerve and impairment there. So I'm definitely going to be ordering some radiology for that.
Okay. What is one myth about musculoskeletal pain management that you would just love to retire?
You don't need a prescription.
Oh,
I mean, so much. Like you're coming to me and it's like, well, I'm coming to a clinician that provides medicine and prescriptions. What prescription am I getting today? Well, we really don't need one. Everything's over the counter. That's the evidence-based first-line treatment. And if we optimize those, 99% of the time, we're not even going to need a prescription.
I love that you said that. I wish we could write that on a wall because I will hear patients say, I saw someone and they didn't do anything.
Yes. Well, they just didn't prescribe anything.
Right. Which means, they didn't write me a prescription. Right. We must not have had treatment.
Right. There's a difference.
That's why referral to physical therapy can go a long way in making patients, it's great for them and they feel like you've done something.
Yeah. If we don't feel like all that education and optimizing our over-the-counter NSAIDs is not enough, because for us it seems like it is, and it's certainly a huge billable documented note.
Yes, you don't need a prescription. I like that. Over-the-counter treatment is great. The interventions are really great. Time.
Yeah.
All right. Well, if you can only come and talk to all my patients, that would be great.
Just bring me in. Now, I'm not saying I convince them, Terry, but I'll certainly tell them.
Oh, this is great. Thank you so much for being here and taking time to join us today. Is there anything else you want the audience to know? You have their undivided attention.
No, I think that we've covered it all. I appreciate the opportunity to speak in Delray, and you all had another podcast too earlier, and was it in April last month? That was covering this too.
Yeah, where we did some cases.
That was really good. I listened to that before we went to Delray. I thought it was very helpful.
Yeah, that was a really good podcast as well. So you can find all of those every place there is podcasts, YouTube, Apple, Spotify. But this one, because it's going to have CE, will also be on our Learning Center. And we're going to give it to everyone at the Cape when they're with us. I'm so grateful that you're here for your insight and guidance.
Thank you. I'm happy to be here.
And when to use those medications. If you want to hear, again, the great foundational lecture that Heather did, you can find it at learn.npace.org. It's actually, I think, in our featured deals section. I think we have it for free there, which will be great. And we're an ANCC accredited provider for continuing education. There will be farm credit with this as well. Thank you again, Heather, for being here with us.
Thanks for having me, Terry.
And to everyone here, we'll see you at the next podcast.